All right, so welcome again to the symposium, and we are now about to begin session 3. So it's my great pleasure and honor to introduce Dr. Mulmenti, Christine Mulmenti. She's associate professor in the Institute of Cancer Research at the Feinstein Institute for Medical Research, and associate professor in the Department of Occupational Medicine, Epidemiology and Prevention at the Zucker School of Medicine, Northwell Health System. I'd like to invite you to the podium to introduce the keynote speaker.
Thank you very much, Dr. Salafu, and good afternoon, everyone. It is my great pleasure to introduce to you Dr. Andrew Rundle. Dr. Rundle has been at the Columbia University School of Public Health, Mailman School of Public Health, and Medical Center for the past almost 25 years. He comes to us with a great experience and leadership. He is the director of the Built Environment and Health Research Group at Columbia University Mailman School of Public Health. He's also professor of epidemiology and project leader for the Social and Spatial Epidemiology Unit in the Mailman School of Public Health. He in his Built Environment and Health Research Group, it's a multidisciplinary team that studies the intersection among our neighborhoods where we live, business and social environments, and those that influence our health and their relationship with obesity and other health risks. He is a SUNY Binghamton graduate with his Bachelor of Science and completed his Master's in Public Health and doctorate at the Columbia University. So without further ado, it's my great pleasure to introduce Dr. Rundle. He's also one of the first people I ever met during my fellowship when I arrived at Columbia as a newbie. His work has always inspired me. He has contributed to the field of epidemiology in a phenomenal way, and he has incredible energy, which is contagious, and I'm sure you'll all really enjoy his presentation. Thank you.
Thank you. Thank you to the organizers for making this event happen. This morning I learned a lot about molecules, biomarkers, ctDNA, and now we're going to zoom way the heck out from molecules and talk about neighborhoods. So I'm going to be talking about the work we've been doing on urban design and how different features of urban design support health, particularly physical activity and the maintenance of healthy weight, and then in turn how that might have an impact on obesity-related cancers. So we're going to be spending a bit of time speaking about obesity and overweight. The definition of overweight and obesity put forth by WHO is an abnormal or excessive fat accumulation that presents a risk to health. Okay, so that's the clinical definition. Our most common sort of like operationalization, I can't even say that, of obesity is BMI. So we use this really crude measure, body mass index, to classify people as experiencing normal weight, overweight, or obesity. And it is essentially the ratio of weight to height squared. And so if the BMI is under 18.5, a person is labeled as underweight. If it's 18.5 to 24.9, they're labeled as normal weight. And if it's greater than or equal to 30, they're labeled as obese. And so I weigh 209 pounds, I'm 6'1". That gives me a BMI of 27.6, really comfortably in the middle of the overweight zone, so I would be labeled as overweight. And obesity is important for cancer for several reasons. So IARC and NCI have linked obesity causally to increased risk for 13 cancers. And so analyses of the attributable risk and attributable proportion that have been done suggest that amongst those who are 30 years or older, annually we see roughly 37,000 new cancers in men and 74,000 new cancers in women that can be attributed to overweight or obesity. And then on the global, sort of the global stage, it's been estimated that about 3.9% of all cancers globally can be attributed to overweight or obesity. Now, physical activity is associated with lower risk of 7 types of cancers. And interestingly, it appears that the way that physical activity prevents cancer is not only by lowering the risk for obesity or lowering fat mass. Physical activity has protective effects outside of sort of just burning calories and preventing overweight or preventing obesity. You've probably all seen maps like this produced by the CDC. This is the most recent one I could find for 2020. This is the map of the prevalence of obesity in America for adults. And you see a lot of red and orange. And the reds and the oranges are areas where 30 to 40% of individuals or adults have reported their height and weight such that we would calculate a BMI of obesity. Hidden within these maps are tremendous disparities by race, ethnicity, socioeconomic status. So I pulled some New York City data. This is the most recent New York City data from the surveys done in New York City, which is 2018 data. And what I've done here is just plotted the percent of adults experiencing obesity by race, ethnicity, and sex. And so what you can see by race and sex and ethnicity, these disparities in the prevalence of people who are experiencing obesity. And we see the highest prevalences amongst Black women and Hispanic women. There's almost no disparity by sex amongst whites, and then we see these gender and race disparities across these groups. You take the same data and then plot it by household income. So the blue bars are men. So there's basically very little trend in income and body weight or BMI amongst men. But amongst women, you see this downward trend, higher income, lower prevalence of obesity. And these are the 2018 data. I've analyzed these data going back sort of year after year. So this exact trend can be plotted in the 2002 data from New York City. So this is a long-standing trend that you see over and over again in the New York City data. So we have these disparities in the experience of obesity, race, ethnicity, sex, gender, income. What about physical activity? So this is the national data for meeting health-based recommendations for physical activity. From 1997 to 2019, we sort of max out at 23% of the population actually meeting the recommendations for physical activity. So we're not doing great on this metric either. This is the national map for meeting the recommendations for physical activity based on health. And that recommendation is 150 minutes per week of moderate intensity physical activity. And so you can see places where less than 20% of people are meeting these goals. And you can plot percent obesity versus percent people meeting physical activity recommendations and do a scatter plot and see this very sharp correlation between the prevalence of the experience of obesity and the prevalence of people who actually meet these health-based goals for physical activity. And you can flip through my slides and you can see that the states that have the darkest red color for obesity have the lightest blue color for physical activity. Colorado is a standout. Colorado has always been like one of the highest physical activity states in our country. One of the things that we've seen using the National Health Interview Survey data is that the prevalence of obesity has increased more rapidly amongst cancer survivors than it has increased in the general population. So I have some graphs here split for women and men, and as I project these slides, I realize our color choices were not great. So the pale blue line down here is the trend in individuals without a reported history of cancer. The other colored lines are the trends in individuals with a reported history of cancer. And particularly for colorectal cancer, you see this sharp divergence between the lines for the prevalence of obesity in these two populations. And you see it in both men and women. And so the population of cancer survivors the prevalence of obesity is growing faster in that population than in the population without a reported history of cancer. If we look at this by race ethnicity, what we have here is the blue lines are women, the yellow lines are men, the dotted lines are without a history of cancer, and the solid lines are with a history of cancer. So amongst Hispanics in the National Health Interview Survey, The blue dotted line and the blue solid line are actually pretty parallel. It's not showing a massive disparity. And likewise, the yellow lines, there's some divergence in those lines, but they're not so far from parallel. Amongst African Americans, though, we see this is where we see this real movement away from parallel lines, right? So the prevalence of obesity is accelerating as depicted by the solid lines. Amongst non-Hispanic whites, these lines all sort of jumble together and fall on top of each other. They're basically parallel. And so amongst non-Hispanic blacks, this is where we seem to have this disparity growing between the prevalence of obesity amongst survivors versus those without a history of cancer. And this is important because obesity has implications for cancer survivorship. And so the experience of obesity as a survivor can worsen a number of cancer-related outcomes. So reduced quality of life, higher cancer recurrence and higher cancer progression, worse survival outcomes, and then higher risk of certain second primary cancers. And then for breast cancer survivors, colorectal cancer survivors, and prostate cancer survivors, physical activity after diagnosis is associated with lower cancer-specific mortality. So both physical activity and adiposity in the survivorship context are important elements of the cancer survivorship experience. Now we zoom out to neighborhoods. So the basic idea of how built environments and social environments might affect obesity is pretty simple. The places where we live, work, and play, the amenities, the physical structures, they influence physical activity patterns, they influence diet. And these environments can be supportive of physical activity, or they can make physical activity harder. They could be supportive of healthy diets, or they may not support healthy diets. And so the question my group pursues is, can we quantify and measure built and social environments, and then can we show how urban design decisions impact health behaviors? We've worked with this idea of walkability. Walkability is a concept that's come out of urban planning, and it describes a set of urban planning choices and features that support physical activity, particularly pedestrian activity. And urban planners talk about the 5D variables. So residential density, intersection density, land use mix, or the availability of destinations to walk to, subway stop density, and this concept of retail building floor area to retail land use. I could explain that to you, but it's kind of arcane. But it describes a kind of commercial and retail environment. And I grabbed two pictures here of a high walkability and a low walkability image. The top one is from the Upper West Side, and the bottom one is from Queens. And you can immediately see differences there. So on the Upper West Side, we've got high population density with apartment buildings. We've got land use mix. We have a mixing of commercial, retail, and residential. We have sidewalks bustling with activity. We have gridded streets. The picture from Queens, which I took from one of the Community District Board websites out in Queens, single family homes, no mixing of residential and commercial space. There's a car in every driveway, and there's literally no sidewalk, right? So these are starkly different in how urban design is gonna support physical activity through pedestrian activity. You can also see the difference just throwing up a Google map, okay? So I've got a high walkability neighborhood on the top here, which is typified by high density, mixed land use, gridded streets, the availability of public transportation. On the bottom, we have another neighborhood in Queens, and you can see the footprints of the single family home, so it's low population density. They have this street layout that's not very connected. It's hard to get from point A to point B. There's almost no stores or retail. The only thing there is Amy's Balloons. So if you have a need for a balloon, you can definitely walk and you can satisfy that need of your daily living by going to the balloon store, but that is it. You're driving everywhere else. And so we can quantify walkability, and we've created these indexes that measure walkability using these concepts for urban design. And we've created a number of data sets for New York City that plot out walkability across New York City. And we can now do this for the entire nation. But in New York City, we can do this at super high resolution. So I do a lot of work in collaboration with the New York City Department of Health and Mental Hygiene. And so one of our first projects was to take the community health survey data that the city has and pool it for 2002 to 2006. And we looked at how features of the neighborhoods in New York City were associated with BMI. And I'm showing you the results of the regression models here, where it's the difference in BMI as predicted by these variables. The dotted red line is the null, the red dots are the point estimates, and then the confidence intervals. And so what you see is that the amount of the zip code that is covered by large parks and small parks is statistically significantly associated with lower BMI. Higher walkability is associated with lower BMI. Conditional on the amount of park space you have, the quality of the park, if the park is low quality, is associated with higher BMI, and the homicide rate is associated with a higher BMI. So this is some of our first work showing that you could take a bunch of urban design variables and show how they were associated with BMI in New York City. We also worked with the Department of Health on a study that had GPS trackers and accelerometer physical activity devices that residents of New York City carried around for a week that collected data basically every 10 seconds. And on the left panel, all of that red is the GPS data that was collected in this study. The data is so dense that you can basically map out the entire street network of New York City just from the GPS data that was collected in this study. And on the right, I'm giving you an example of one of the ways we use this data. So we wanted to understand how New Yorkers use their neighborhood. So the circles each represent a 1 kilometer space around the person's residence. The dots represent their GPS activity, and the white areas represent the smallest polygon that can contain that GPS data. So we tried to segregate like a 1 kilometer space around their house into places they used and places they didn't use based on their GPS activity. And what we find is that in your neighborhood, your average New Yorker is going to use the most walkable portion of their neighborhood. And so this is the walkability score, index score, for the area that they actually used in their home neighborhood based on their GPS data versus the area that was within 1 kilometer that they didn't use. And I've plotted the walkability index score, and you can see it's significantly higher. And so what we're seeing here is walkability influences people's behavior and where they go in their neighborhoods. We also looked at their physical activity patterns. So what I've plotted here is a covariate adjusted predicted minutes of physical activity across quartiles of walkability in New York City. And you see this really nice upward trend as walkability increases, the amount of physical activity increases. The difference between the lowest and the highest quartile is 100 minutes of moderate intensity physical activity. Now remember, your health-based recommendation is 150 minutes. So variance in neighborhood walkability accounts for 2/3 of the health-based recommendation for physical activity in this sample. So this is a huge effect size. And so this association is really, really strong. So this is all modern GIS data from the 2000s. We wanted to start linking GIS data to cohorts that have been in existence for decades. And so we had to figure out a way to use quite primitive, not very clean administrative data from like the 80s and 90s to start measuring physical neighborhood walkability. And so we started building metrics that we can roll back all the way to 1990. And we use population density, intersection density, the number of destinations for daily living, and rail transit. But realistically, population density and the destinations of daily living are the two pieces of data that we can readily get anywhere in America fairly easily. So we've ended up with very intense work being able to use all four in some occasions, and then when we're going nationally, we end up only using these two metrics because we just don't have the resources to measure all of this everywhere for 30 years. So we partnered with New York Women's Health Study. This is a cohort study of 14,000 women originally recruited between 85 and 91 at mammography screening centers in New York City. And we've got now the entire address history for this cohort is 400,000 addresses for these participants. And so we've been able to build a full cohort analysis of walkability that they experienced during follow-up in this cohort. And at baseline, we use sort of our high-tech version, which has 4 metrics, and then for each year of follow-up, we use this sort of easier-to-measure measure that only has population density and destinations. But these two metrics are highly correlated with each other. And so what did we see? On this left panel, this is at baseline, so this is back in 1990, and what I'm doing here is plotting our neighborhood walkability index versus the self-report engagement in pedestrian activity and walking. And so what you can see here again is this trend. As walkability goes up, the self-report of engagement in pedestrian activity goes up significantly. And then when we look at the BMI of the women when they were recruited into the study at baseline against the walkability of the neighborhood they lived in, again, what you see is this strong association between higher walkability and lower BMI in this cohort at baseline. So this is like way back in the late 80s, very early 90s. When we look at the hazard ratio for obesity-related cancer mortality, so we take the baseline walkability back in the 1990s, and we use that to predict cancer-related mortality for obesity-related cancers. And what we see is that neighborhood walkability at baseline predicts lower risk of mortality from these obesity-related cancers. And so this is sort of like the first finding that we had. It was like, all right, this is what was happening at baseline. What happened to these individuals through 30 years of follow-up? Maybe they didn't just always live in this neighborhood. So we started looking at creating an annual metric for walkability throughout follow-up in this cohort. And so here is the average annual neighborhood walkability throughout follow-up for all of the women in the cohort. And again, what you see here, this is the risk of obesity-related cancers. And as neighborhood walkability increases, the risk of diagnosis of an obesity-related cancer significantly declines. If we just zoom in on postmenopausal breast cancer, which is sort of like the archetype for a obesity-related cancer, again, we see the same association. So the hazard ratio for diagnosis of postmenopausal breast cancer goes down significantly as neighborhood walkability or the experience of walkability goes up through time. So this is the first set of work really showing that an urban design feature measured over 30 years with exquisite follow-up of where people lived is associated with lower mortality from obesity-related cancers and lower incidence of obesity-related cancers. We've done a little bit of work on cancer survivorship. So I'm involved in 2 cancer survivor cohorts that are both focused on African Americans. The first is Detroit Rocks, which is 2,089 African American cancer survivors living in the Detroit area. They have a first invasive breast, prostate, or colorectal cancer. And we measured BMI at the initial recruitment into the cohort, which was about 20 months after diagnosis. The other study is the Women's Circle of Health follow-up study, which is a cohort of African American breast cancer survivors. Baseline data collection was roughly 10 months after diagnosis, and they've had a follow-up now. So 12 months after that, there was a follow-up, and then once again, they collected height and weight to measure BMI. So in our Detroit cohort, looking at just one BMI time point, so the first BMI that we were able to collect after diagnosis, again, we're seeing the same thing that we've seen over and over again, that neighborhood walkability is associated with lower BMI. And so what I'm plotting here is the difference in the BMI of the cancer survivors by neighborhood walkability after adjusting for these various variables. And again, neighborhood walkability is inversely associated with BMI. The nice thing about the second study is we were able to look at weight gain and weight loss after diagnosis. And so what I'm plotting here is the risk of weight gain after diagnosis based on the density of walkable destinations. So walkable destinations is like all the stuff that you need to go and do, like banking, shopping, that you could walk to in your neighborhood as opposed to living in a neighborhood where the only way you could do that is to drive somewhere. So places that have got all of these amenities we need for our daily lives are much more walkable than places where you have to get in your car and like drive to the plaza or the mall or whatever. And what we show here is that as this sort of walkable environment increases, the risk of weight gain goes down significantly again. So now we have 2 data points showing that walkable environments are associated with lower adiposity amongst cancer survivors, amongst African American cancer survivors, where we actually see the biggest disparity in weight gain post-diagnosis. So follow-up on these cohorts is ongoing, so I'm hoping to have many more dots to plot in the future as we start plotting out trajectories of weight gain in these populations through time. And so the conclusions I have thus far is our work and that of many others shows a consistent association between higher neighborhood walkability and higher levels of physical activity, lower BMI, lower obesity risk, and less weight gain through time. This is the first data that I'm aware of showing that neighborhood walkability is associated with a cancer outcome, and in this case, multiple cancer outcomes in terms of mortality, incidence, and survivorship experience. And based on our work in the National Health Interview Study, is the African American cancer survivor population that seems to experience the highest uptick in weight gain. And so we're showing here that urban design seems to be associated with a lower risk of weight gain. And again, this supports urban design policies that support physical activity, right? And so every urban designer, every city government is making choices about how to spend money to build and rebuild and refurbish cities. We're trying to build the evidence base that you can use design decisions to support health through physical activity. And we've had some luck translating this into policy. And so we worked really closely with the New York City Department of Health. And so our findings immediately sort of flow into the Department of Health. And so we've authored data briefs that the New York City Commissioner of Health publishes on design and physical activity. Our findings are part of the scientific basis for the current urban design and building guidelines that have been set by New York City government. One of the things about New York City is when New York City sets a policy, like other municipalities tend to download that policy and enact it. So this policy for physical activity support through design is now sort of being used by lots of other cities. Our work is used by for-profit design companies as part of certification programs for healthy design, and also not-for-profit organizations that put together certificate programs. So I'm an advisor to the Weill certificate program, and I'm an advisor to the Center for Active Design on their FitWell certificate program. So we're actively trying to turn this into policy decisions, but also get this information into the commercial building, the commercial design, the commercial architecture world as well. This is a huge team effort. This is a small smattering of the team, doesn't even include my students who have been working on these projects. This is a giant team effort that brings together urban planners, urban sociologists, biostatisticians, geographers, epidemiologists, environmental health scientists. And we've been lucky enough to be funded and supported by NIH and foundations, and supported by colleagues who have these beautiful cohort studies that we work with. So thank you. And I hope I'm on time. I might be a little ahead of time.
That was an excellent talk. Thank you very much. What a great presentation. I wanted to open the floor up for questions, both for those of you here in person and for our Zoom audience. But I'll just get things started. I had a question regarding the one slide that you showed regarding the fact that only 23% of U.S. adults meet the physical activity recommendations. So as we think about different racial and ethnic minority groups, does that same statistic apply, or does that change by group? And then in a follow-up question, what does the walkability look like in some of these neighborhoods? And is there less opportunity for getting activity, and how does that impact obesity in these minority populations? Thanks.
Sure, thank you. Good questions.
Okay.
I've never actually pulled apart the physical activity data by sociodemographics, in part because a lot of the survey data doesn't have great measures of physical activity. Like, it's super easy in a phone survey to get people to report their height and weight, but then doing the kind of survey that is required to gather all the information you would need to figure out if somebody has met those requirements. So we have a lot less data, really, on physical activity. And New York City has published its data, makes it super easy to look at it by all of these sociodemographic variables, but it's less easy to do that for physical activity. It would not shock me at all if that 23% figure was different for people of different backgrounds, incomes, and situations. The question on what does walkability look like in different places. So sort of one of the critiques that anybody in this room should be able to throw at me is, let's talk about fundamental causes, right? So let's talk about income, poverty, and how have I tried to adjust for confounding for that, right? Like, so we put into all of our models measures of individual level SES and neighborhood level SES, so measures of poverty, income, median household income. But the other thing to think about really is that, like, some of our neighborhoods that are relatively low income are actually much, much more walkable than our wealthier neighborhoods. So if you think about some of the wealthier, more suburban neighborhoods of Queens, they actually aren't that walkable when you compare them to, say, 125th Street and Amsterdam. So tons of retail, tons of subway, gridded streets. So one of the things we see is that wealthier neighborhoods actually have sort of lower walkability metrics when we talk about walkability from these purely urban design concepts. And so this kind of flips the usual environmental disparities story on its head. We usually think of low-income neighborhoods, communities of color, as having more pollution, right? More of these negative environmental features, and we think about environmental justice. But when it comes to urban design for walkability, it actually turns out that it's very common for disadvantaged neighborhoods that are disadvantaged in other ways to actually have higher levels of walkability. And that flips our confounding story on its head. The experience of walking in a wealthy neighborhood versus a low-income neighborhood may be quite different, though, right? So one of the things that we sort of link with low-income neighborhoods is higher crime rates. And so often we actually have data on crime rates, and so we can adjust for that. And so when urban planners talk about walkability, they're really talking about a design construct. They're not talking about so much an experience construct, right? They're talking about, like, we're going to build some stuff. Mm-hmm. They're not talking about how we craft this so that it has these other aesthetic qualities or the way you feel about it. So we do our best to adjust for social determinants of health. There's always going to be residual confounding, but we also sort of take comfort from this idea that the script has been flipped, that disadvantaged neighborhoods often are more walkable, and that changes our sense of confounding and how things may get biased.
Mm-hmm. That is very interesting. That is an interesting point to think about, because people higher income can join a gym. They can get exercise, but there's also something called the active couch potato. The person that says they exercise, they tick the box that they work out, and they ride their bike to work, but they sit for 8 hours and then ride their bike home, and they call themselves exercisers. And then you have someone else in west side of New York walking all day long, and they would never check the box that they exercise. They're just living.
Right, they're just doing their daily living activities,
Correct.
right? Yeah.
Correct.
And I think that, like, sedentary behavior is not at the opposite end of the scale of physical activity. It's like it's an orthogonal scale. It's a separate thing, right?
Yeah.
So I did my 30 minutes on the treadmill this morning, and I walked here from the subway station, but I've been sitting all day, and I probably count as sedentary. But that's on a different sort of dimension than the fact that I hit my health-based recommendation for physical activity this morning.
Correct. Which has all types of implications for measurement error, as we know in epidemiology studies. Yep. So very, thank you for answering my questions. Are there other questions in the audience?
Thank you so much for giving us this spatial setting. How do you account for air quality? So when people walk outside, they're also exposed to air quality, and therefore it might, in some places, be safer to drive. And then also in New York City, we have the inequitable distribution of street trees, meaning that people who have higher walkability in the summer also have much greater exposure to the sun, and therefore walking may not be healthy. Thank you.
Yeah, I mean, so there's a lot to unpack there. So on the air pollution front, I think it's on LinkedIn, maybe it's on Facebook, but there is a discussion between myself in the public chat between myself and an air pollution researcher questioning our results. So higher walkability tends to be associated with higher air pollution. And his argument was that air pollution is associated with cancer, right? But it's an inverse confounding triangle. Not to get deep into the epimethods weeds, but we're showing that walkability has got a negative association with cancer. walkability is positively associated with air pollution is positively associated with cancer. So our failure to adjust for air pollution is probably functionally a bias towards the null. And so if we were able to control for air pollution over 30 years across the entire country, we're expecting to actually see a stronger effect of walkability because of the way of those correlation matrices would work. And it's interesting, right? Like you could say, well, if I go walking on a busy street and I'm sucking down all that air pollution, that can't be good for me. On the other hand, it appears that physical activity is so good for you that it seems to offset, trump, or outweigh, whatever you want, however you want to say it. Like physical activity still seems to win as a protective effect. Yeah, street trees. One of the things that street trees do is they keep air pollution concentrated at the ground level in New York City because street tree canopy acts as a ceiling, and then you've got the canyon walls of the buildings on either side. So street trees are actually associated with higher ground level pollution. They do make a nicer walking environment, though. So I could definitely see like green space and street trees being positively associated with more walking. And we've done some work that bears that out. What we have seen is that park space is good for lower BMI, but not on the same order of magnitude as walkability. And so parks in New York City are destinations for physical activity. They're also destinations for laying around and doing nothing. They're also destinations for eating, like some of these parks with like amazing food trucks. And so like teasing all that apart when you do a study of green space is kind of hard. Not everybody goes to the park to exercise, but they are destinations for exercise. So I hope that was somewhat useful in answering your questions. Uh-oh.
Excellent presentation. Thank you. And I really appreciate the slide where you're showing the translation to policy. I think it's really important. One of the questions that I had was actually about measures, other alternative measures of adiposity instead of BMI, because we know body mass index is not necessarily the best measure of adiposity across racial and ethnic groups. So have you thought about, or have you done any work looking at the relationship between walkability and some of the measures of the design features of neighborhoods, and how they might relate to things like waist-to-hip ratio, and even measures of adipose tissue distribution, say from CT scans? And that's a question because I'm actually doing a study like that right now that I think would be really interesting to look at, looking at adipose tissue distribution.
We have looked at waist circumference in the regards cohort, and we actually find a bigger impact on waist circumference than BMI. And the regards cohort is an older age cohort where there's some sort of like loss of muscle mass and gain of fat mass. And waist circumference is actually more strongly associated with walkability in a good way. I was very skeptical of BMI for a long time. I've become less skeptical. I think that we did a paper where we took a huge clinical data set and we could measure body composition, percent fat, percent muscle, waist to hip. We basically took every measure that was in the literature that we could measure that depicted adiposity, and then looked to see which of these measures was the strongest predictor of blood pressure, cholesterol, blood sugar, and they were all basically the same, and none of them did any materially better than BMI in this huge clinical data set. And so that made me feel a lot more comfortable about sort of thinking about BMI as a measure I wanted to measure. I would also say that in large population studies, the argument against BMI is it doesn't measure muscle mass. Right? Like you could always say, well, I'm heavy because I have a lot of muscle. That's obviously why I am in the overweight category. On a large population scale, like New York City, we do not have an epidemic of buffness, right? Like that's not what we see clinically, is an epidemic of just like musculature, right? And I think within the setting that we're in, BMI works quite well. And it has all these drawbacks, absolutely. It doesn't actually measure the thing I want to measure, but as a proxy measure, it does good, and it's really predictive of future health outcomes. as good as anything else that I could possibly measure in 10,000 people, right? So that's my thought on BMI. And no, it's not a great measure. It doesn't measure the thing I want to measure, but it does measure something that's important.
I also really enjoy your talk. I have a sort of question comment. Have you compared with other cities around the world? Because, like, of course, in Europe, it's much more, cities are more walkable, but also villages. But there is something that I was commenting with my friend, who is also from Spain. So over there, women, postmenopausal women, are always walking in groups. I mean, there is culturally in many countries all these walks that people do after a certain age. So I'm interested as well to see if there is, and is there anything in addition culturally in some cities in the US, in some behaviors, I think there is a lot there that could, be unpacked.
I mean, the vast expanse of America is not very walkable. So the study from the NYU Women's Health Study, these were individuals recruited from Connecticut, New York State, New Jersey, so lots of suburban areas. And then through time, many of these individuals moved to like Florida and like some of our typical retirement states. And so we were able to sort of have like a fairly strong diversity. It wasn't like everybody was from like Manhattan. So we had fairly strong diversity of spaces. And in the regards cohort, which I haven't shown, the regards cohort is a national study. And it gives us like all kinds of walkable environments. And we've published analyses there showing that walkability is associated with lower weight at follow-up and smaller waist circumferences. I think like social norms, like you're explaining, of groups of people going out for a walk together, I think that just like, as a social intervention, I love it. If that could be combined with sort of urban design that made that a even better experience, that would be great. My work is very much focused on crunching very, very large data sets in sort of very abstract ways, and I don't really do a lot of like intervention studies or behavior change studies,
Hi, thank you. Thank you for your talk today. I have a question and also a comment. My question is the slide that you spoke about women, survivors of cancer being overweight. My question is, do they gain weight after they finish treatment, or these women were already heavy before? And then my comment is, I thought it was interesting, the slide you had of people of different economic circumstances, and generally the women had more obesity than the men until the very rich, that the men popped up. Mm-hmm. And I didn't know if you knew about that, if you looked into that.
So for the last question first, we've seen the same phenomena for 20 years of data in New York City. It's amazing how stable that graph is. I think that the story of socioeconomic status and weight in women is in part a story of stigmatization of body. It's in part a story of there's a significant bias in hiring and pay raises for women who are have a larger body size. And so there's sort of like a loop going on here. And I think for men, basically if you're rich, there is no social stigma for being overweight. Like there is very little social pressure for that. And I think that's why we see almost no impact of SES in men, and we see it only in women, and we see it over and over and over again. Sorry, you distracted me with the last question. The first question again, give me the keyword. Yeah. Right. So in the National Health Interview Study, which was like the beginning of our work, it doesn't let us tease that out. In the 2 survivor cohorts that we're working on, we're hoping to tease that out because we're hoping to have long-term follow-up where we can look at what happens before and after the end of treatment. At the juncture we're at now, we don't really have it's a little fuzzy on how many people have finished treatment, and we don't have like enough data points post-treatment to really like plot out trajectories. But the goal very much is to try and plot out the exact trajectories I imagine you would like to see.
I just had maybe one final question related to diet. So similar to you were talking about the walkability counters the pollution part. We know diet plays a role in obesity. I wonder if walkability, if you've teased apart any data that took into account diet and walkability.
So we've published papers where we've both measured the walkability environment metrics and food access in terms of like fast food and grocery stores and so on. On a national, if you look across the nation and you look at the literature published across the nation, there's very few papers showing an association between food access near your home and diet or body size, in part just because everybody just drives to the grocery store. In New York City, where car ownership is much lower, we actually do see associations between your immediate neighborhood food environment and diet and BMI. And it appears to be more about the availability of healthy food. So we didn't see any associations with the density of fast food. And I think that there's so much fast food in New York City that like one more Burger King in your neighborhood doesn't radically change your diet, because you could still eat 21 meals in a week at the fast food joints. But we have much lower density of supermarkets and places where you can buy healthy food. So there we actually saw an association where there was greater access to supermarkets was associated with lower BMI. And as a result of that, we worked with New York City on their Fresh initiative, which was a series of tax, zoning, loan programs to get supermarkets to open up in underserved neighborhoods. I think we're up to 32 supermarkets have opened under the Fresh initiative. And so, translation of research to policy, I went and testified at the city zoning board. They gave me 2 minutes to make my case that we should change the zoning laws in New York City to allow supermarkets to open in places where they typically wouldn't be allowed to open because of zoning. So I had to speak really fast for 2 minutes to make the case that zoning should be changed so we can open supermarkets so people could eat healthy. So yeah, we worked to change zoning, and so now there are, we did a small part of that, and New York City was able to change its incentive structure. So I think there are 30-odd supermarkets and grocery stores that have opened as a result of that. So what we found was healthy food, access to healthy food. We could see health benefits of that. The density of fast food was not associated with health outcomes, and I think it's just because, you do a regression model where you're like, what is the effect of one more fast food joint on health when you already have 30 fast food joints, right? It doesn't really make that much difference. So we've done the work. Walkability still is the strongest predictor compared to green space or food access. Not that I don't think food access is important. I'm just saying in our data, it didn't show up as well.
Are there any other questions on anyone here on the Zoom? Any Zoom questions? No? Okay. All right. Dr. Rendell, thank you very, very much for that awesome presentation.
Thank you all.
And your incredible contributions to this field. Thank you. Thanks.
All right, so the last session really has to do with the social determinants of health and their relationship with cancer. And we have Dr. Camacho-Rivera to moderate the session. We have 3 speakers. Dr. Camacho-Rivera is Assistant Dean for Student Affairs. So if you are looking to be an MPH student in the School of Public Health at Downstate, she's the one to talk to when she comes up, and you see her when we finish the symposium. Talk to her about your future needs in public health. She's going to be moderating the session, so please welcome, join and welcome Dr. Camacho-Rivera to the podium.
Great. Thank you, Dr. Salafu, and it's a pleasure to continue the conversation and moving upstream to continue to talk about social determinants of health and cancer disparities. It's my pleasure to give a very brief bio for our first speaker, Dr. Margrethe Horlyck-Romanovsky. Dr. Horlyck-Romanovsky is an assistant professor in health and nutrition sciences at Brooklyn College. Dr. Horlyck-Romanovsky completed her Master of Public Health and Doctor of Public Health degrees from the CUNY Graduate School of Public Health and Health Policy, and completed additional postdoctoral fellowship training at the National Institutes of Health. And Dr. Horlyck-Romanovsky's career is dedicated to addressing health disparities and inequities in New York City underserved communities, using both community-based participatory research as well as epidemiological methods and approaches. Dr. Horlyck-Romanovsky founded and leads the Immigrant Health Lab at Brooklyn College, and her lab's research focuses on intraethnic health variation in populations of African descent and adaptation of nutrition assessment tools to better capture dietary intake among immigrant populations. And today she'll be presenting some really interesting heterogeneity research on cancer risk among Black New Yorkers. Welcome, Dr. Horlyck-Romanovsky.
Thank you so much for that introduction and for the opportunity to be here. I'm really excited to be challenged to talk about something new, but really informed by the work that we have done in my lab, demonstrating that classifying people by race first is a gross error. Again, my name is Margrethe Horlyck-Romanovsky, and I will be discussing today the significance and really importance of accounting for origin and lived experiences and disaggregating our epidemiological studies and even electronic health records data so that we can incorporate information about variables that might affect our genetic predispositions, but also that there are differences between growing up in one place versus another. So let's see if I can do this. I have no disclosures. So you may ask how this work started, and I'll explain briefly because it's really important. It's rooted in Brooklyn. Since 2012, I've taught a diverse set of courses at Brooklyn College, and when I taught community nutrition, I sent my students into the neighborhoods around the college to ask people what was important, what were they worried about. And the things that came back from Brooklyn, which is extraordinarily rich and diverse community, was diabetes, hypertension, and cancer. And so in our previous works, we have tackled the diabetes issue, and we've demonstrated that the risk profiles and phenotypes in African immigrants, Afro-Caribbeans, and African Americans are distinctly different. So are their ability to manage the disease once they develop diabetes, and therefore we have, I hope, informed both clinical practice and epidemiological studies. We actually were the first to demonstrate this in New York City using some of the same data sets as Dr. Rundle has used for the first time to demonstrate that classifying people by race obscures differences between groups. And that goes in both directions. Those with lower risk are perceived as having higher risk, and those who have higher risk are perceived as having moderate risk than they actually have. So, and cancer health disparities are often discussed in terms of differences between racial and ethnic groups. We look at racial groups as monolithic, homogeneous groups, and that really obscures those differences. And so we disaggregate not just in African descent populations, we also look at Asian descent populations. But today I decided to tackle this issue because it's really close to my heart, and because we know from previous research that when we disaggregate the Black population groups, we demonstrate that the lived experiences in places of birth, the genetic history, and the level of exposures to various variables vary greatly. So we know from epidemiological studies that growing up in a majority Black society is healthier and produces healthier people than growing up as Black people where they are a minority. And so when people move from sub-Saharan Africa or the Caribbean in majority Black societies to the US, they actually are healthier and maintain that health when they move to the United States. So today I'm going to talk about the cancer experiences and journeys a little bit for Black, Caribbean, African American, and African immigrants, and how they vary in risk and mortality rates. We have very little to no data on detection and prognosis, which is what I'm advocating for today. I want to remind you that when we talk about race, and we've generalized by race first, we perpetuate inequities that we are truly trying to eradicate. And I think that disaggregating the groups will further inform the conversation around how irrelevant race is as the first separator. It should be a part because, sorry, we live in a racist society, but it cannot be the first divider between people. So the assumptions in the United States from the health disparities data is that African American people, or all people with Black skin living in America, have higher rates of obesity, obesity-related cancers, smoking, and other cancer risk factors. Prevalence of social determinants that lead or increase the risk of cancer and worse outcomes, later detection, are higher. Higher risk of cancer overall. We assume that there's a higher risk of late detection, a higher risk of dying prematurely, and a higher risk of mistrust in the healthcare system. So today I'm going to show you some information that will tell you about the heterogeneity as it relates to a couple of cancers and why this is particularly important in New York City. So in New York City, about 24% of the population considers themselves and report themselves as being of African descent. And as illustrated in the red bubbles here, people of African descent come from many different places on the planet. A majority, of course, are people who are multi-generational descendants of enslaved people that were brought by force to the United States. And a large share are immigrants from the Caribbean who were brought to the Caribbean for similar reasons. Then in addition, we have immigrants from sub-Saharan Africa, and those are more recent arrivals. And then embedded in the African-American sample are descendants of recent immigrants who very quickly become classified as African-American because they were born here. In addition, Black immigrants make up about 32% of the New York City Black population. That's a third who were not born here and therefore have very different lived experiences. But data scarcity of origin makes it difficult to get a current estimate, and that in spite of the fact that Black immigrants are the fastest growing group of immigrants in the United States and in New York City. According to the Pew Institute, Black immigrants used to be primarily of Caribbean origin. At this point, African immigrants make up 42% of Black immigrants to the US. So this is the fastest growing and most rapidly contributing, and by the way, have the lowest risk of all cancers, most cancers, I should say. So our work focuses on New York City. This is a map of where people live by their self-reported race. And as you can see, the concentration of people of African American and Afro-Caribbean descent, I don't know if you can read the key, but, and I didn't choose the colors, but the burgundy and pink, and you can see it in central New York, in Far Rockaway, and in Jamaica, and in the very northern end of the Bronx and in Harlem, are the concentrations of populations of African descent, primarily African Americans and Afro-Caribbeans. But as Dr. Rundle has referred to, survey data often conflates the terms, and people are not given the opportunity to report their actual descendancy. But this is just to show that in New York City, we have right around SUNY Downstate, right around Brooklyn College, we have an opportunity to collaborate with communities that are part of this history. And And then what we already know in cancer research and people of African descent in America is that the higher risk, higher rates, higher death rates, lower overall 5-year cancer survival rate than whites, and that Black women are more likely than white women to be diagnosed with breast cancer and overall lung colorectal cancers at a later stage. So I pulled up a couple of studies because we have actually not tackled this yet. We have requested data and we're looking at it, but the data is, that's always the challenge in epidemiology. The data is not always available to answer your questions. But I looked at a couple of publications, there are a few more, that looked at this disaggregation. So Pinheiro et al. Published a paper in 2020. They looked at vital statistics data from California, Florida, Minnesota, and New York City, or New York, I should say. They looked at 83,460 cancer deaths among Black people. And they compared then to a much larger sample of 707,000 cancer deaths among white people. And what they found was that African males and females had the lowest all sites combined cancer mortality, 121 versus 232 for male, and 99 versus 163 per 100,000 people for females. And Afro-Caribbeans were in the middle with a moderate risk relative to the referent, and that the average Black-white risk ratio was significant for prostate, endometrial, stomach, multiple myeloma, premenopausal breast cancer, liver, and cervical cancers. And in general, they found that African American people had 30% higher all cancers combined mortality risk than whites. Afro-Caribbean people had 23% lower all cancers combined mortality, and African people had 37% lower mortality risk than white people. And so this study shows that when we combine the three groups into one, and we have a sizable or significant contribution of Afro-Caribbean and African immigrants in the Black sample, we obscure the fact that African Americans, so multi-generational African Americans, have a higher risk than the data actually shows when we look at a monolithic racial category. When we look at the ratios between the different groups, we see that this is the data that I just reported, but in the actually data table, you can see the higher overall risk in African American and the lower, all statistically significant relationships in the immigrant groups, both for men and women. And so in general, and this is something that our lab has focused very much on, is immigrants are typically healthier than the US-born population they're compared to, and therefore they obscure the worst health in the US-born population. So what they concluded in the study was that US-born Blacks had the highest mortality rates for common and infection rates related cancers. Caribbean Blacks had intermediate rates, and African Blacks had the lowest rates. There were some exceptions. One was prostate cancer in West Africans and liver cancers in East Africans that are associated with hepatitis, history of infectious hepatitis. And then what they argue is that research on genetic and environmental risk within Black population is absolutely needed. And one thing they noted was that an explanatory variable may simply be that Black immigrants have historically smoked less than African Americans. Another study that looked at Florida cancer data, a cancer statewide cancer registry, Florida has a very diverse Black population, in part of it because of its proximity to the Caribbean. And they looked at women in particular who were diagnosed with invasive cervical cancers in the lifetime span between 1981 and 2016. And then they looked at US-born whites or Blacks and compared them to Caribbean-born whites or Blacks. And what they found was that US-born Black women had the lowest mean age and diagnosis. So now we're complicating the narrative here because there are differences in when diagnosis happens. Caribbean Black women were diagnosed at a later stage of disease, but in general, US-born white women and Caribbean white women had better outcomes than US-born Black and Caribbean Black women. So even though there are disparities in the age and the timing, the outcomes also differ. So the hazard ratio for Caribbean Black women and Caribbean white women had better odds of long-term. So race alone is not a determinant of cancer mortality in women with cervical cancer, but understanding the importance of nativity on cancer is crucial to improve the health outcomes. A third study, also by Pinheiro et al. From 2016, a little older, also looked at Florida health vital statistics and looked at cancer mortality data for 5 years. The challenge with the data is most of what we have about cancer that can be disaggregated is death data, because on death certificates you have to indicate where someone was born. In many other places, you do not. But they looked at 20,000 cancer deaths in Black populations, and they computed cancer mortality rates in US-born Black people, Haitian people, and Jamaican people. And what they found was that the risk of death from cancer was 2.1 times higher, so double, for US-born Blacks than Black Caribbean men. And in women, it was 1.6 times higher for US-born Blacks than Black Caribbean women. So again, here we see the disparity is affecting negatively the US-born Black population, where the immigrants are at an advantage. And so they again have a similar conclusion that race is not a determinant for cancer mortality. I want to disclose that race may very well be a determinant, but in this case, it is not. Racism may be. US-born Black people had the highest mortality, and Black Caribbean people had the lowest mortality. And in fact, in lung cancer, US-born Blacks had nearly 4 times greater mortality than Black Caribbeans. And again, that might be linked to smoking and the history of smoking, the culture around smoking, and smoking as a coping mechanism, and the aggression of the tobacco industry of targeting particular markets. So that might be disappearing, that healthy immigrant effect. And then migration from the islands of Haiti and Jamaica to Florida means that there are lower cancer mortality for most cancers for people who move to the United States rather than remain in the home islands of cervical, stomach, and prostate cancer, but there might also be higher or stable, so same mortality for colorectal and endometrial cancers. So, and last but not least, they also found that US-born Black men have the highest incidence rate of aggressive prostate cancers in the world. So why is this important to New York, and how do we know that this is that we can do this with the data? So I pulled a table from a previous publication with the Community Health Survey. We can usually aggregate 5 years of data, which gives us a strong and large sample that we can look at. And about 11% of the sample are African immigrants, and 75% of the sample are Caribbean immigrants. And then we have a sample of 15% of other foreign-born Blacks from other regions of the world. And so we can disaggregate the data in New York City. So I just want to show you also the diversity of the data that we have in New York City. So we have looked at African or Caribbean region of origin that's based on specific countries of birth. African origin was defining as self-identifying as Black, having been born in sub-Saharan Africa. And although not all the countries that are highlighted on the map, it's very few that are not represented. The list is on the right. The major sending nations to New York City are Ghana and Nigeria from the African region. And similarly from the Caribbean nation, we work with a broader Caribbean designation that includes continental countries such as Belize, Guyana, and Venezuela. In New York City, the fraction of Caribbean is made up of, let's get the last one here, primarily Jamaicans, and then Trinidad and Tobago, Guyana, and Haiti. And so we have sizable samples to actually disaggregate by country of origin, which is really important in terms of genetic heritage. So in conclusion, race does not explain cancer risk. Combining African American, African, and Afro-Caribbean people really obscures things and obscures important differences. It obscures the higher risk in subgroups, and it obscures the lower risk in subgroups. And we need to collect information about individual and family history, lived experiences, origin, time in the US. Those are essential. And we also need to collect data about history of food insecurity, of smoking history, other factors that can up or down regulate genetic predispositions in previous generations. One of the biggest shortcomings we have is lack of family history. And that comes also from regions where access to medical care and medical records is limited, if not non-existent. Implications for clinical care. I urge everyone to not make assumptions based on a patient's perceived race. I urge everyone to recognize heterogeneity, ask people about their history, and consider this incomplete family medical history because it's really, really important to understand that people don't know. And then call for region and sex-specific screening guidelines, questions to ask, work with culturally competent medical staff that can ask these questions in a non-threatening manner. And then I would encourage you to collaborate with us on upcoming research and studies, and also interventions on these topics. I also have some implications for public health. We really have larger and systemic issues that are leading to these increasing rates of, or high rates of cancer that we have to address. But we can only do it if we have the data and we can demonstrate at the population level that these are issues. We also do not capture experiences of stress, trauma, racism, and genetic variation in our epidemiological studies, and I really strongly urge us to do that. And then I want to tag on to Dr. Rundle's presentation that we also need to work on creating healthy environments so that those who arrive as healthy immigrants remain healthy people. So collaborate with us. Talk to me about how we can have other adjacent areas. I've already spoken to a geneticist, and I look forward to the questions at the end. Thank you.
Thank you for that presentation. And at the end of the presentations, the three presentations, I'll ask all of the panelists to please come back and join me on stage to be able to take questions from the audience in person as well as via Zoom. I'd like to next provide a brief introduction for our next speaker, Dr. Erica Phillips. Dr. Phillips is the Jack Fishman Associate Professor of Cancer Prevention and an Associate Attending Physician at NYP Hospital and the Sandra and Edward Meyer Cancer Center and Weill Cornell Medicine. Dr. Phillips is trained as a clinician, scientist, and health services researcher, having obtained her medical degree from Columbia University College of Physicians and Surgeons, completing her internal medicine residency at University of Pennsylvania Hospital, and her MS degree in clinical epidemiology from Weill Cornell Medicine. As a health services researcher, Dr. Phillips' research focuses on three intersecting areas: developing behavioral interventions to promote healthier eating, physical activity, and weight control in high-risk groups, conducting formative qualitative and quantitative research to understand social determinants that drive differences in chronic disease inequities among certain racial and ethnic groups, and incorporating strategies around community-engaged research approaches to be integrated into larger scientific programs that address health inequities. And today she'll be speaking on her collaborative work examining food insecurity amongst cancer survivors across New York State. Thank you, Dr. Phillips.
I kind of say it's always great to be home. I went to elementary school just next door at PS 235, and my first job was being a file clerk here at SUNY Downstate in the Department of Cardiology. Back when, in middle school you can get your working papers, and my mom was like, okay, go do that. Okay. So I think I have the pleasure of following up a talk that kind of leads into what happens actually to immigrants when they come to the United States and are faced with an environment that is very different than their own. And one of those major factors that we see now is related, obviously, to food insecurity. And so I'm going to talk a little bit about discussing food insecurity as a social risk, not only for cancer incidence, but also as a downstream consequence of new cancer diagnosis that impacts the health-related quality of life of cancer survivors. To identify actually the impact of the COVID pandemic on food insecurity among the general population and comparing that to cancer survivors across New York State. And then lastly, thinking about and looking at opportunities that we've seen actually come out of the pandemic, and how do we capitalize on keeping those opportunities going forward based on some of the evidence that we saw where we actually did see closure of some of the gaps as it relates to food insecurity based on income and based on the social construct of race. So I'll say actually this work stemmed out of my interest in starting the first, what we now know to be called New York State Cancer Healthy Eating, Active Living Action Team. So for those who are familiar with our New York State Comprehensive Plan, as you can see, it has expired. We are in the process of the next 5-year plan still rolling out, but the last 5-year plan, which stemmed from 2018 to 2023, covered these priority areas. And amongst those priority areas, my talk today is going to focus on sort of two of them, which is health promotion and cancer prevention. And as I said, how does food insecurity link to that as a social risk? And then survivorship. Within the overarching goals of the Comprehensive Control Plan is to really serve as a guide for community members, policymakers, advocates, healthcare professionals, and others to really engage in the efforts locally and across the state in terms of cancer control and prevention. All of the action areas, there are measurable objectives, and those measurable objectives obviously are usually linked to some sort of data set where we can follow and track that. For anyone who's ever gone to the New York State Cancer Consortium's website, there's actually an active dashboard, as you can see how we are doing across the state regarding these measurable objectives. And so as it relates to two of those areas that I'm going to cover today, the New York State Cancer Control Plan for 2018 to 2023, you can see that there were a number of lists of measurable objectives, but 4 of them in particular touched on as it relates to the primary prevention of cancer related to 1, reducing obesity, and 2, improving access, or I should say improving fruit and vegetable consumption, and decreasing physical inactivity. Most of the objectives are always every 5-year period set to have a 5% reduction point as it relates to the overall objective. And so that's pretty standard as it relates to the plan. So what you'll see is all of them tend to be a 5% reduction. When we think about food insecurity as a social risk for incident cancer, we know, and first of all, that broadly our definition of food insecurity refers to a condition of having inconsistent access to adequate food to maintain an active and healthy life. Most recently, actually, in 2021, the NIH, along with the CDC, 2022 going into 2023, put together a panel, one of the first NIH nutrition workshops as related to food insecurity, neighborhood food environments, and nutrition health disparities, looking at sort of the state of the science. And that actually was led by a colleague of mine who recently returned to Cornell University, which was home for her, which is Angela Odoms-Young. And so Dr. Young led this conference with many individuals across the state participating, across the state and country, I should say, some who may be in this room, and many within the New York area, like Dr. Francesca Gainey, who's also a member of our action team, who very much are sort of at the head of looking at how to address food insecurity amongst cancer patients. And so two of the things in terms of the state of the science as we think about why does food insecurity or how potentially food insecurity leads to incident cancer was one, thinking about or looking at the altered metabolic process, in particular through the stress pathway. And I think that is extremely important to immigrant populations as they come to the US, when coming from a country where you are the majority to now being defined a minority, experiencing racism first and foremost in a way that you probably never have experienced before. I think I forgot the comedian's name, who said he didn't realize he was black and from South Africa until he actually came to the US. And so it is a very awakening moment for many. And so that stress pathway, as we know, is really important in terms of our hypothalamic pituitary adrenal axis and the stimulation of glucocorticoids and what it does to our insulin. Also pathways we see contributing to visceral fat deposition and accumulation. And then second is also thinking about food insecurity as it relates to poor nutritional quality and its impact on the microbiome. And again, in terms of creating these pro-inflammatory environments. And so on our left, we sort of have the common stigmata of, what do fat cells or adipocytes do as it relates to the proliferation and creating a microenvironment that's prone to cancer cells in terms of, as we know, in terms of premenopausal breast cancer and its impact on estrogen, which I think we'll probably hear a little bit next. Insulin growth factors as it relates to the propagation in the microenvironment for cancer cells, and then obviously inflammation. And so we sort of create this tripart environment that is very much liked by cancer cells. And obviously, unfortunately, as we also know, that there are now 13 cancers that are very much associated with overweight and obesity, likely all for varying different reasons related to these sort of three mechanisms that we just highlighted on the left. So while food insecurity is a social risk for the incident cancer, it's also been associated with delayed cancer screening. And so in 2019, out of 9 of the NCI comprehensive centers all came together after the administrative supplement that was provided by NCI for cancer centers to do population level assessments. And they nicely pooled their data to take a look at and harmonized to see, as it related to these social risks, how they might have been associated with, for example, in this case, colorectal cancer screening. And by pooling their data, they had close to about 5,000 individuals that they could look at from that eligibility standpoint, and in breast cancer, where they had, by pooling their data, about 2,500 individuals. And what they saw was the prevalence of food insecurity first amongst the population when they pooled their data ranged anywhere from 18.2 to 21.6%. I want you to remember that those percentage points, those will become important as I talk about our New York state numbers and New York City numbers. And that was amongst colorectal cancer and breast cancer screening participants, respectively. And what they found was that food insecurity was inversely associated with being up to date for colorectal cancer screening and breast cancer screening. And so here we see other areas in which food insecurity, not just from an incident standpoint, but from a potentially delayed, and when we see delayed screening, we see late-stage presentations also is associated. So then next, I'm just going to move on to the area of survivorship, which is where I'm going to sort of focus the rest of the talk. We know that the overarching other goal is obviously to not only decrease cancer, but improve at least the quality of life of those who are unfortunately diagnosed with cancer. And so this article by colleagues that was in JNCI in 2022 sort of very nicely sort of walks us through why a cancer diagnosis may lead to food insecurity. And we know a lot of that has to do with the financial toxicity currently related and associated with a cancer diagnosis. Treatment leads to time off work. Time off from work often can lead to loss of work completely, or early departure from the workforce, leading to financial strains, not only in the individual, but in their households, leading to reallocation of resources. When we talk about reallocation of resources, we're now talking about the battle between, do I pay for my medicines that help to suppress my cancer, or do I pay for the food that keeps everyone in my house filled, or myself? And we begin to see food insecurity in stark magnitudes. Secondary to that, and along with that, we see obviously the battle that many individuals face, which is just treatment decision-making in the first place. Do I eat or do I take meds? And so we then obviously see worsening outcomes in many different ways. And so that brings me to the initiation of the Healthy Eating and Active Living Action Team, which I serve as the co-chair, along with one of the other community advisory board members for our cancer center, the Sandra and Edwin Meyer Cancer Center at Weill Cornell. The action team does span the state, and we have several members, and I'm going to put an unshamed plug in for you to attend. In June, we'll be hosting the first quarterly meeting focused on our efforts of the action team, which was initiated in 2022. So I'll make sure to send out the information to those who have put this symposium together so that you can attend to learn more about what our action team is doing. But our goals, our mission of our action team is obviously committed to diminishing the statewide impact of cancer and enhancing the well-being of all cancer survivors. We strive to achieve this by formulating and advocating for policies in particular and resources that create an inclusive environment where individuals from diverse backgrounds can flourish. Our focus is on fostering active living and encouraging the adoption of healthy nutrition practices to improve the overall quality of life for all. And so one of the things that I showed you before as it related to the current previous 5-year objectives was, as we sort of began to meet as an action team, what we felt really needed to be a focus and was not a focus was the upstream factors that make it difficult for people to decide and to choose healthier nutrition. And so we began to think about what would be a proposal for the next 5-year plan of more equitable objective measures, especially those that really begin to address the social and structural determinants rather than the individual behavior of, did I choose to eat fruit and vegetables today or not, versus I don't have a choice about, can I eat healthy fruit and vegetables today? And so our objectives, in order to do that, we first needed to think about, again, what were the upstream factors that we could impact on? What was first the magnitude of food insecurity, which actually prior to that had not really been stated as it relates to what is the magnitude of food insecurity amongst cancer survivors within New York State. What is the magnitude of food insecurity amongst cancer survivors compared to the general population? And then because we formulated the action team in 2022, we were interested in knowing, well, what impact did COVID have on the numbers prior to? Were we in a worse situation than we were before? Were we in a better, or where were we, period? And so our group got together and actually got together with one of our state evaluators who helped support our ability to access the New York State BRFSS data. And so we set out to examine the influence of the pandemic on food insecurity amongst cancer survivors pre and post the pandemic. I would say probably not post, interim of the pandemic, so 2019 versus 2021. Using the behavioral risk factor surveillance system, the state had actually added a module starting about 3 years ago, I think it was, as it related to looking at 4 years ago, as it related to looking at food insecurity. And the food insecurity question that's asked in the modules, how often in the past 12 months would you say you were worried or stressed about having enough money to buy nutritious meals? And individuals answer responses who stated always, usually, sometimes, rarely, or never in response to that question. Food insecure individuals we defined as those who reported that they were always, usually, or sometimes worried or stressed about having enough money to buy nutritious meals within the last year. Cancer survivors, defined by the BRFSS, are any respondent, regardless of how long ago they were told by a doctor, nurse, or other healthcare professional that they had any type of cancer other than skin cancer. This latter nuance is something that the state has done over time because of the inability to actually distinguish melanoma and non-melanoma skin cancers, and being that usually non-melanoma skin cancers do not require treatment, felt that that group was separated out. And so we sort of followed the same guidelines that they've been using to determine cancer survivors. Our covariates of interest were a number, as you can anticipate: age, sex of birth, self-identified race, education, income, employment status, marital status, number of children in the household, health insurance, and total number of chronic health conditions, which we did a very simple count, looking at those health conditions that have been in the literature previously shown to be associated with the burden of food insecurity. We used standard analyses as related to, with the BRFS, doing weighted and unweighted descriptive statistics to describe the population. We performed chi-squared analyses looking at characteristics among 4 cohorts. And so in the 2019 cohort, we looked at cancer survivors versus respondents without cancer, same thing for 2021. And then in our multivariate model, we chose the most evidence-based variables and those with a significance value of less than 0.1 to include in the final model. We also further looked at the difference of food insecurity amongst cancer survivors in New York City versus the rest of the state. The New York State BRFSS allows you and has a particular modules as it relates to being able to differentiate those who are residing within the 5 counties of New York versus the rest of the state. And so while it might be a little bit hard to see all of this, I'm just going to highlight some of the big points, which was when we looked at in 2019 prior to the pandemic. This represents a little over 14,000 respondents to the survey. We see that food insecurity was not actually higher in cancer survivors by percentage-wise 17.78% versus 19.5% in the general population. We do, obviously, as we would expect, see that the cancer survivors' significant difference was that they were older in age, that they were there was a greater proportion reported to be female. There was no actual difference in their BMI status. By race, actually, the self-respondents who were cancer survivors were a greater proportion self-identified as white. And from a disability status, again, no surprise there that individuals were more, there was a higher report of disability status amongst cancer survivors. Other important factors not shown here, I didn't show the entire table since it's a pretty large table, was that those who were employed for wages still was a lower proportion of individuals who were cancer survivors were employed, but the actual unemployment rate was not different other than those, the larger percentage of, there was a greater percentage of cancer survivors who were retired. So in 2019, pre-pandemic, what we see was that amongst cancer survivors had a higher odds of being food insecure if they self-identified by a non-white race. The odds ratio was about 2.3. If they had a household income less than $25,000, so there were 2 income categories, one less than $15,000 and then between $15,000 to $25,000. And if they had more chronic health conditions. While non-white race and low income were also significant predictors of food insecurity in the general population, the determinants of age, less than 65, female gender, having been widow, separated, divorced as a marital status were also significantly predictive of being food insecure in the general population, but not so in the cancer survivors. And it's likely because of, at least when it came to the age difference, because it was a group that was more predominantly over the age of 65. However, on the other hand, private health insurance and being out of work for less than a year actually in the general population was also, the individuals had a lower odds of being food insecure, but that did not pan out for those who were cancer survivors. And in what we see during the pandemic, interestingly, was that the odds of being food insecure amongst cancer survivors actually began to attenuate for non-white race. And so before, where we had an odds ratio that was about 22, we now saw an odds ratio of about 15. And so while it didn't close completely and didn't become insignificant, we do see some suggestion of an actually decrease or attenuation for race and for income as it related to the odds of being food insecure during that period of the pandemic. Additionally, the odds of being food insecure was lower if you had private health insurance compared to no health insurance at all. So what we, again, overall did not see significant change in food insecurity or a worsening of food insecurity in cancer survivors compared to the general population as an effect of the pandemic. What was quite interesting was the difference in food insecurity in New York City versus the rest of the state. And so what we see in 2019 and 2021 was that food insecurity amongst cancer survivors was about 1 in 4, pretty much pre the pandemic, and again post the pandemic. And so we're talking about 1 in 4 cancer survivors across our state, in New York City in particular, were food insecure. And if you remember back to that earlier slide where those 9 cancer centers pooled their data, their highest rates of food insecurity was 21%. So that speaks to the fact that we do have higher food insecurity rates than many other states. So the take-home points from the analysis was that food insecurity prior to and during the pandemic has been disproportionately experienced by cancer survivors residing in New York City compared to the rest of the state. In fact, the burden of food insecurity amongst cancer survivors in New York City exceeds the general population by almost twofold. And although the pandemic led to higher food insecurity rates across the state, the overall change in prevalence amongst cancer survivors, regardless of residency, was not significantly different. And we do think that this suggests that many of the, as we know, the substantial amount of food policies that had evolved as a result of the pandemic potentially was protective for many vulnerable populations, why we did not see an incremental jump in those rates. And so we do think that as an opportunity to learn from that. We are interested in taking a look at this data as a cross-section again, now that many of those protective waivers have gone away, to see what the impact is and to see if we've reversed back or gotten worse. But overall, from these results, we were able to, for our 5-year plan, actually put together a proposal of more what we consider to be equitable objectives for the next 5-year cancer control plan for the state. And so what we have proposed that instead of focusing on the individual behavior that people believe leads to obesity, we focus on the structural and social determinants that we clearly have demonstrated from everything that we did during the pandemic, that we do have the ability to actually change policy, and the opportunity to do so is now. And so by 2029, we have put forward the proposal to decrease the percentage of households with at least one child under the age of 18 living outside of New York City and in New York City who report food insecurity by at least 5 percentage points. Again, remembering that what I stated was that generally 5 percentage points is the average focus that the state makes for each of these objectives. And then in particular amongst cancer survivors, that again, focusing on New York City, given that our rates in New York City exceeded that of the rest of the state by substantially, that we really need to focus on reducing food insecurity amongst cancer survivors in New York City by 5 percentage points. And then one of the other equitable measurable objectives that we put forward, which still doesn't stand, currently is not a standard, is that all patients undergoing active cancer treatment or are within at least their 5 years of treatment completion should be annually screened for food insecurity by validated measures, and then obviously focusing on addressing that as a quality measure amongst cancer survivors. And I think that's it. Thank you.
Thank you. Hold on to those questions. We do have one last presenter before we open it up for a discussion. It's my privilege to be able to introduce Dr. Adana Llanos, who is an associate professor of epidemiology at the Mailman School of Public Health at Columbia University and a member of the Cancer Population Science Program at the Herbert Irving Cancer Center. Dr. Llanos obtained her degree, PhD in genetics from Howard University and her MPH degree in epidemiology from the Ohio State University, completing additional postdoctoral fellowship training at the Lombardi Comprehensive Cancer Center at Georgetown University, as well as the Ohio State Comprehensive Cancer Center. And Dr. Llanos' research and scholarship focuses on deepening our understanding of the biological, social, and structural determinants of health on cancer outcome inequities, with a lens on being able to inform cancer survival, improve cancer survival among vulnerable populations by translating this epidemiologic evidence using novel evidence-based multi-level strategies. And Dr. Llanos will be presenting on exploring the combined impacts of contextual factors and allostatic load as contributors to breast cancer inequities. Welcome, Dr. Llanos.
Thank you so much for that introduction, and I really thank the organizers for inviting me to speak, and I thank all of you for staying till the very end. So today, my talk will be split into 3 sections. I'll start by sharing some of our research connecting allostatic load with breast cancer. In the second section, I'll really talk about some neighborhood factors and contextual factors that we've shown, well, our group and others have shown relates to poorer outcomes from breast cancer in some groups. And then I'll end with a few slides that just focus on a few of my own thoughts about how we might address breast cancer inequities in the future. So as I mentioned, the first part will focus on allostatic load as a biomarker of breast cancer. So allostatic load, as early as the early 1990s, was conceptualized and introduced by McEwen and Steller as the cumulative consequence of repeated stress or repeated exposures to external stress. And it's in the attempt to maintain homeostasis under chronic stress, especially long-term exposures to stress. This process really is a way for our bodies to promote necessary adaptive regulatory processes during those stressors. And it's necessary, as I mentioned, for maintaining homeostasis, but also for maintaining a healthy state. When we're exposed to stress long-term, these systems can become dysregulated. And so in that process, the hypothalamic, pituitary axis, and sympathetic nervous system are chronically stimulated and alters biomarkers and messengers in the cardiovascular system, metabolic system, and inflammatory system that ultimately leads to this maladaptive process that we call allostatic load. So this process of achieving and maintaining allostasis or homeostasis can fail, and that's what we see with allostatic load. Several studies have shown that long-term exposure to external stressors and the related upstream factors, so these social and structural determinants of health, leads to an accumulation of physiologic dysregulation. And that's what we measure as allostatic load, or physiologic stress. It's an early marker of increased morbidity and increased mortality. And there is evidence that allostatic load differs by self-identified race, also by ethnicity, and socioeconomic status, as early as in childhood. And in 1992, the weathering hypothesis was put forth by Arlene Geronimus as a possible explanation for racial inequities that were observed in maternal and child health outcomes. And this hypothesis states that the health of African American and Black women begins to deteriorate in early adulthood as a physical consequence of the cumulative socioeconomic disadvantage. studies have since shown that higher levels of allostatic load and higher allostatic load scores are also associated with breast cancer. So first, I just want to show that, as I mentioned, allostatic load scores differ when we focus on self-identified race. And we know race is a social construct, but I just want to share the data that we have showing these differences. So in this graph, you can see, and these are data from NHANES, we can see that across race and gender, so we have data here for white men, white women, black men, and black women, and you can, hopefully you can see the symbols. But you can see over all age groups, there's an increasing probability of higher allostatic load scores, so a score of 4 or greater. And you can see that for black women and black men, higher allostatic load scores are higher at every age. Also in the NHANES study, they looked at a cross-sectional relationship between elevated allostatic load score, and here they're operationalizing elevated allostatic load as a score of 3 or more. And what we see is that in white women, there really is no difference in elevated allostatic load scores when you're comparing women with or without a history of breast cancer. But when we look in black women without a history of breast cancer, they have about a 35% probability of having elevated allostatic load. But those with a history of breast cancer, that risk is above 50%. And so the conclusion from that study is that higher allostatic load score is cross-sectionally associated with breast cancer in black women. So the odds ratio indicates that the risk of breast cancer was twice as high among black women with elevated allostatic load. But what we see is that there is no association between allostatic load scores and breast cancer in white women. So this was a cross-sectional study, and we were really interested in examining whether there's a prospective relationship where allostatic load scores measured before diagnosis is actually being associated with breast cancer outcomes. And I'll present some of the data shortly. But before getting to that, I just wanted to mention that there is currently no gold standard used across epidemiologic studies to compute allostatic load. And overall, allostatic load has been operationalized as a variety of different indices or computations of biomarkers across cardiovascular, metabolic, inflammatory, but also neuroendocrine, depending on what biomarkers are available in the cohort or the data set being analyzed, allostatic load scores can be operationalized differently. But what I'm showing here is that across 21 publications using NHANES data, these are sort of the most frequently used biomarkers to compute allostatic load. And here, these markers circled in pink are the ones that are more consistently used in cancer epidemiology studies. And so I think at this point there is a consensus in cancer epidemiology literature that measuring allostatic load, you have to incorporate biomarkers from the cardiovascular system, the metabolic system, and inflammatory or immune system. So the research question we had was, is there an association between pre-diagnostic allostatic load scores and breast cancer outcomes among Black women? So we looked at this question in the Women's Circle of Health study, and we did 2 studies. The first study focused on whether pre-diagnostic allostatic load score was associated with more aggressive tumor features or more unfavorable tumor features at diagnosis, and then 24 months later, so 24 months after diagnosis, we wanted to know whether higher allostatic load score was associated with poorer quality of life. So our allostatic load score was based on biomarkers assessed from medical records of our participants. And those biomarkers were assessed 12 months before their diagnosis. And in the Women's Circle of Health study, we were able to collect self-reported data through questionnaires. We also had data from the New Jersey State Cancer Registry, which is where most participants were recruited from. And we also requested access to medical records, and so that's how we were able to get these data. So the tumor features were from pathology records at diagnosis, and health-related quality of life was assessed using FACT-B 24 months post-diagnosis. And so you see this is the first study attempting to do this prospective analysis. And this was done in a small sample of women from the Women's Circle of Health and the Women's Circle of Health follow-up study. And 409 women were those whose medical records were retrieved at the time we started the analysis. So I want to show the two computations that we used. I mentioned that there is no gold standard, so one of the goals was also to examine what happens when we measure allostatic load in different ways. So the first measure we classified as a lipid and metabolic profile-based measure, and you can see what the biomarkers were: systolic and diastolic blood pressure, waist circumference, serum glucose, total cholesterol, high-density lipoprotein, triglycerides, and the use of medication to control hypertension, diabetes, or hypercholesterolemia. Our second measure was an inflammatory profile-based measure, and the only difference are the three biomarkers that are bolded. So we had body mass index, EGFR, and serum albumin. So we examined the concordance between these two measures, and we found that there was fair to moderate agreement. So the kappa statistic was 0.5. So not perfect, but among the 229 participants where we had both of those measures, that's what we found, that it was pretty consistent. So in terms of the relationship between pre-diagnostic allostatic load scores and breast tumor characteristics, we found that with the lipid metabolic profile-based measure, elevated allostatic load was associated with poorer tumor grade. I mean, overall, you can see that there is, a trend for increasing odds of more unfavorable breast tumor features, but for the lipid and metabolic profile-based measure, only the tumor grade was statistically significant. For the inflammatory profile-based measure, we found that elevated allostatic load score using this measure was associated with increased odds of poorer tumor grade, so higher tumor grade, as well as larger tumor size. When we examined the relationship between the lipid and metabolic profile-based measure with health-related quality of life 2 years post-diagnosis, we found, again, that there's this increasing trend for increased odds of poorer quality of life looking at each of those sub-scales within FACT-B with higher allostatic load score. But for this particular measure, none of the estimates were statistically significant. When we look at the inflammatory profile-based measure, we see that elevated scores for this measure was associated with significantly higher odds of lower functional well-being and lower FACT-G score, so general quality of life, 24 months post-diagnosis. So I mentioned that this was the first study attempting to evaluate a prospective relationship between chronic measures of chronic cumulative physiologic stress. And what we found is that these pre-diagnostic measures of allostatic load might be associated or might be a consequence or might lead to consequences including more unfavorable tumor features such as higher tumor grade and larger tumor size, but also with poorer quality of life 2 years post-diagnosis. Recent evidence from prospective studies also suggest that there are associations between pre-diagnostic measures. So some cohort studies, and I'll actually present some of this here. So 2 recent studies, actually published in the last 2 months, investigated these prospective associations, and here's what they found. So the first study was done in the UK Biobank, and again, they're using a very different, not completely different, but sort of different computation for allostatic load. They included 11 biomarkers, and then this study was from the Women's Health Initiative, and they used an 8 biomarker score. You can see some similarities, and again, it really is based on what measures were collected at baseline for these studies. So the first study in the UK Biobank, they found that the risk of breast cancer increased by 5% for each 1 unit increase in allostatic load score. And in the Women's Health Initiative, they categorized allostatic load scores into tertiles, and they found that the highest tertile was associated with 36% increased risk of breast cancer, especially for the luminal A subtype. And so you can see it's 54% increase for that subtype. And there's one other study that was recently published that examined the relationship between allostatic load scores and mortality among women with breast cancer. And this study was conducted using an electronic health record data set from Ohio State. And they used a 10 biomarker score. And they found that higher allostatic load score was associated with an increased risk of all-cause mortality among women with breast cancer. So these investigators categorized, they classified allostatic load into quartiles, and the highest quartile was associated with 79% increased risk of all-cause mortality. So when we started this work in our lab in 2015, there were several gaps in knowledge, and we attempted to address them by really looking at the prospective analysis. And since then, we've seen some new investigations that really support that there is this association between chronic stress measured before diagnosis with a variety of outcomes among individuals with cancer. And so some of our new interests are standardizing allostatic load computation so that we can consistently use a standardized measure across studies. So this will allow us to validate the use of this marker, as a marker of risk, a marker of prognosis, but also a marker to help us understand inequities. And as the title of my talk suggested, I'm also very much interested in understanding how the combined impact of upstream factors, structural racism and related measures, which we know are related to allostatic load and related to stress, how do these factors together contribute to breast cancer incidence, breast cancer phenotypes, and breast cancer outcomes? And I think studies that really incorporate a sociobiologic or a biosocial focus will help us to define the mechanisms of persistent breast cancer inequities, but also help us to guide what we can do about it. So we talked a little bit about policies that might need to be developed. I'll next talk a little bit about some of the evidence connecting contextual factors at the neighborhood level, but also broadly in research. So I want to start with this image, and you've probably seen this image before, but in some of our earlier talks, we've heard about the impact that where we live really does impact our health outcomes. And I would say that place is much more predictive of our outcomes than race. So in this slide, we can see that simply living approximately 2 miles away, there's this huge disparity in life expectancy. So just thinking about this example of zip code versus genetic code, or zip code versus race, we should be thinking about how does where we live affect the cells in our body, affect the biology in tumors, affect the tumor microenvironment, and how can understanding these relationships help us address inequities. So some of our work focusing more on characteristics of neighborhoods that could be really driving some of these associations is neighborhood investment versus disinvestment, or disinvestment versus investment. And you can see two different types of neighborhood here, very similar to what Dr. Rundle presented earlier. But this measure of neighborhood disinvestment is something that our lab has collaborated on quite a bit. So what you can see on the neighborhood on the left is what neighborhood disinvestment might look like. Graffiti, debris, boarded windows, abandoned buildings, crumbling sidewalks. And you don't see these things on the right. What you see on the neighborhood in the right includes things like well-kept buildings, green space, walkable sidewalks. We know now that walkability in neighborhoods relates to both obesity, adiposity, but also cancer risk and outcomes. Some of our findings using data from the New Jersey State Cancer Registry actually shows that living in neighborhoods with higher levels of neighborhood disinvestment was associated with underinsurance, late-stage breast cancer diagnosis, higher grade tumors, triple-negative breast cancer subtype, and worse survival outcomes. We also conducted a study that focused on 1930s homeowners, loan corporation mortgage security redlining. So by redlining, I mean the government-sponsored practice of denying individuals access to mortgages based on the location of properties in minority and low SES neighborhoods. And so here we're looking, this is just one area of Essex County in New Jersey, and you can see the areas that were marked red are hazardous or the worst, and you can see going up to the green, these are the neighborhoods that were desirable. So one of the things that we found, examining the relationship between residing in a neighborhood that was redlined in New Jersey and the risk of breast cancer outcomes, we found that present-day residents in a neighborhood that was redlined back in the 1930s, 40s, and 50s was associated with worse outcomes. So increased odds of late-stage diagnosis, increased odds of higher grade tumors, increased odds of triple-negative subtype, et cetera. We also looked at the reverse. So if you were someone who did not live in a neighborhood that was redlined, you actually had lower odds of late-stage diagnosis, lower odds of high-grade tumors, and lower odds of triple-negative subtype, as well as lower odds of breast cancer-specific death. So all of this really shows that there's a potential intergenerational effect of a historically racist policy like residential redlining. So redlining is now illegal, but we're still seeing the impacts on health today and breast cancer outcomes today. And I think that just further documents the importance of understanding the structural and social determinants of health. So I also want to mention, I'm a geneticist by training, and I'm interested in how biology and genetics might play a role in some of the inequities that we see. But for the most part, a lot of what we're seeing is not really explained by genetics, and race is not a biological construct. However, suggested by this slide, is there has been an underrepresentation of Black and African ancestry populations in research focusing on cancer genomics. So there's a lot of missing data when it comes to genomics that we would really need to address. And here I'm using an example of the relationship between pathogenic variants in a variety of genes and how they might relate to, or how they contribute to racial disparities in triple-negative breast cancer. So mutations in the BRCA1 and 2 genes, as well as in other genes like BARD1, PALB2, RAD51, C, RAD51D, as shown in this figure, supports that there is an association between germline susceptibility and genetic etiology of these tumors. However, Black women have not been represented at a high level in the research. So we don't know that these mutations actually occur more frequently in Black women. It's just they might potentially be occurring more frequently in the sample of individuals that have been included. And as we learned earlier, it is critical that we disaggregate groups and not just base our analysis of associations by race on this social construct that really combines or categorizes heterogeneous groups. And I also want to mention another important issue is the underrepresentation of diverse study participants in clinical trials. So here on this slide, what I want to convey is that Black individuals, or individuals who self-identify as Black, accounted for 12% of all breast cancer cases diagnosed in 2020. But they accounted for only 3% of the clinical trial participants for FDA-approved breast cancer drugs between 2008 and 2018. So despite being more likely to be diagnosed with more aggressive tumors, more advanced stage, and even at younger ages, these women are not being represented in these studies that could lead to treatments to improve outcomes. So policies have been put in place to increase the representation of women in clinical trials. Now we need policies that increase the participation of Black women and other underrepresented groups in trials as well. And I would just add that the diversity of trial participation should also be considered in terms of age, in terms of geography, and in terms of other sociodemographic characteristics. And that's the only way we can ensure that the individuals that ultimately end up using these drugs were represented in the studies that tested them. So I just have like 2 more slides, and they're really just my thoughts. So I wanted to talk about the cells to society or society to cells approaches to really understanding the mechanisms through which our society, our lived experiences, our behaviors, all of these factors really get under our skin and cause inequitable outcomes. I think, really incorporating these measures, so not just focusing on the individual, but really focusing on systems, on policies, will really help us to get to a place where we can address inequities, because inequities exist at all of these levels. And I would say actually disparities, which are just differences across groups, exist at all of these levels, but it's the inequities that we actually can change, because the term inequity means that there is some injustice that's happened, and I think that's the part that we have to address. And so this slide is really getting at this comprehensive focus on multi-level determinants. We can develop interventions that target individual behavior, but we've seen that that's not necessarily going to make a huge difference in equitable or inequitable outcomes. So things like policies, norms, health systems, these are probably going to have a much more broad impact. And I would also say communities, intervening at the community level will also make a difference. Yeah, so I'll end there. I think I might be over time. But I just want to acknowledge that all of the work that I've presented has been a collaborative effort. just really highlighting the Women's Circle of Health study team. In this picture is one of the doctoral students who's now a graduate that helped design some of these studies, and my collaborator, Jessie Plasick, and these are some of the field interviewers and the PI from the Women's Circle of Health study. And here's my contact. Looking forward to discussion.
Great. So we are actually right on time to be able to take questions. So I'd just like to invite the panelists back up. And we will start with taking questions from the audience.
Thank you to the speakers for a very enlightening session. My name is Nyasha Chambwe. I'm at the Feinstein Institute for Medical Research. And this question is for Dr. Margrethe. I think in your talk it was very illuminating, and I think we don't think about the subgroups within individuals of African descent with enough precision as you made us aware today. My question to you is, you mentioned the fact that you also have looked at immigrants who've come here and have quickly lost sort of the immigrant protection, I guess, or lowered risk for developing certain cancers. Can you speak to a little bit more about those types of studies? How many generations does it take to lose the effect of immigration? And also, how do we go about studying those types of phenomena?
We need a lot more money. So I should preface this with, I argue against a lot of the research we've previously done on the effect on immigrants and immigrant health. We have some unpublished studies where we've talked to generations of West African immigrants from Ghana and their children. And we're seeing that the historical, I think it also may vary by immigrant group and time and in US history, that now it is much more socially acceptable to retain your cultural identity from back home. And so I think what we will see is merging, and we have one paper out on Ghanaian immigrants that we talk to youth and elders or parents and grandparents, that the effect does not actually disappear as easily as we think. And one of the reasons why it may, in certain immigrant groups, certainly in African and Caribbean immigrants, is that there is a focus on getting the children who come, either are born here or who are brought over here, to get a higher education and a higher socioeconomic standing. And so by default, they are in a different position than their parents. But so they're really reaping the benefit of their parents having healthy lives and being healthy immigrants who were able to immigrate and succeed. And then they get the socioeconomic jump. And if they go to college, they come back and they're somehow able to combine the best of two worlds. And I call it the teenage bump. They do have a bump of junk food when they're teenagers, then they go to college and they come back, and their social norms have changed around physical activity and diet. And so my hope is that we're actively producing these first 1.5 or second generation children or youth who are combining what their parents and grandparents taught them from back home and what we now think of the most desirable social norms and behaviors. And that goes for smoking, alcohol consumption, et cetera.
And a follow-up related to that, are there genetic and other biomarker-based studies that can show that there's a lot of shared genetics amongst these different African subgroups, that the effects are primarily environmental, and you've measured that somehow with some environment-based biomarkers, like the biomarkers we saw on the allostatic load measurements?
So we're going to have to talk. But, and I'm not a geneticist, but I do know that we say that there is more genetic variation in the sub-Saharan African continent than in the rest of the world combined. And so we can't, I know from diabetes research, we cannot identify whether there's a particular gene in sub-Saharan Africa. I think they did a genetic study on diabetes. There's like 357 genetic predispositions that are present in the sub-Saharan African genetic pool. That's not something that we can use to say, to screen for, right? So I think I agree with your point. We cannot, genetics is just a small fraction. The only place where genetics may play a role in cancer epidemiology is that because of the torturous and violent history of enslaved people, the genetic pool that was brought to, say, the Caribbean islands was much smaller and has had much less admixture in certain groups. And so we do see like triple-negative breast cancers that are far more common in Caribbean women and actually emerge at younger ages. But I would say that's the exception rather than a rule.
I would just add that I think, when I, and I'm going to make this very personal. So I'm a Caribbean immigrant, and I wanted to study genetics because I thought that would be the way to understand disparities. The longer I've studied it, the longer I've stayed in this field, I realized that I think genetics might be more important for understanding how to treat disease rather than how to ascribe some genetic marker to specific groups that explain their disease, right? Because when we think about environmental exposures or anything non-genetic, those are the things that we can change to promote healthier health outcomes, right? Like we can modify our diets, we can modify the exposures, the things that we're exposed to. So I think that it is more like understanding how all these external things impact maybe epigenetics, right? Not the genetic sequence, but what the genes are doing. So that's where I've sort of diverted my research, is to really looking at the social determinants of health and epigenetics rather than how specific genetic variants determine who is going to have a poorer outcome than the other.
Hi, I think I'm next in the questions. I wondered for Dr. Romanovsky, I wondered if there were any studies about the differences between those who are migrating from the countries you described now and those who may have been migrating some time ago, and the degree to which remaining sort of a core group from your country influence the way you raise children and grandchildren, et cetera. And are we looking at that anywhere?
Thank you for that question. I can't say that I have done a systematic review of the literature, but I think I have a pretty good sense of the limitation of the literature on cancer inequities and disparities within the Black population. As I mentioned earlier, cancer data is very hard to come by, and accurate data about where people are from is hard to come by. And we almost never have those two things, plus how long have you been here, how old were you when you arrived. We have that in some of the community health survey data. We can sometimes calculate how long have people been here, and we can then calculate, because we know how old they are, that people know. They know how old they were when they came here, and then we can figure out how long were they in their home country, or we can make assumptions about that. But most often, we don't have all of the data points, which is why I'm calling for much more accurate data. And I think we have an opportunity to collect that kind of data. We just have to figure out what kind of data do we think actually matters, and how. And I loved your diagram But it's very costly to ask people questions, except when they sit in the waiting room for their doctor's appointment. You know, you already fill out all these questions. That's where those questions come from, somebody who wants to answer difficult questions. So the answer to you is, we have a lot of circumstantial evidence of sociology, anthropology about immigrant experiences, but we can't translate that into clinical outcome. We can't make the connection unless we ask those questions and pair them with this data. And that is not available, unfortunately.
Did you want to respond? Because I have a question.
I was just going to say that I think, that's a great question, and I think that it goes across not just those of African ancestry, but multiple different cultural groups. I think some of the, when you started to ask the question, the first thing that comes to mind is the term cultural enclaves, right? And which is that the ability to migrate to a country and continue to live the same way that you lived at home in that country, in the sense of the foods that you purchase and the stores that you go to, and the ability to actually get through your entire day speaking your very home language and not actually have to be forced to speak English in order to get through your day, I think makes a big difference. And I think there are pockets in the city. I belong to currently a network of centers across the country funded by NMIHD, and there was a young lady, a young investigator actually, who is at NYU, the Rutgers Center, and I think where she gave a very lovely talk, I think, on looking at cultural enclaves, in particular in Asian Americans, especially here in New York, looking at the ability to being able to migrate, and the protection and the social capital that are often measures that we also don't talk about, but are also very important to finances, and what it means to have multi-generational households is what is what we're talking about, which is that is part of wealth building. And at the end of it, a lot of this is the one factor that I don't think we talked about enough is the difference in poverty, right? Poverty, money is green. And whichever culture you're in, it's the same green that makes a difference and probably is a greater driver than even, I think, race as it relates to some of the inequities that we see from a poverty standpoint. And that has a lot to do with, I think, these cultural enclaves that are protective for some and not as protective for others.
So I just want to add that there are epidemiologic evidence that show a protective effect of enclaves or residing in an enclave for Hispanic and Latinx communities and for some Asian groups. But again, Black populations have been understudied. So to my knowledge, there are no studies that have looked at the impact of foreign-born or U.S.-born Black groups that form these enclaves, right? So I think that there's a lot of opportunity for research here in New York City, which is probably the most diverse in terms of the Black subgroups that are here. And again, it highlights the importance of disaggregating and even really drilling down more on lived experiences, like how long you've lived in this country, and how your duration here impacts stress and impacts wealth, all of these questions. These are things that are related to health outcomes broadly, but specifically for cancer risk and outcomes.
Thank you. There's a question over here.
Persons who were here from the Caribbean, we wanted a mango. We just went right out and we pick a mango, right? We wanted an orange. We went on the tree and we picked an orange. We wanted to eat chicken. We went in the chicken coop. We pull out chicken. We crack the neck. We feather it and then we boil it. No preservative, no hormones, nothing sprayed on it. So growing up in the Caribbean, we never knew nothing about when it comes to cancer and all those things, because everything that we ate straight from the ground, we could, as they say, organic. We knew organic from back home. So those things, they never really bother us. But flipping it on the other side is that being here for the day, and then the persons who really put this forum together, kudos to you, thank you very much. I'm happy to be here. I learned a lot, and I learned a lot on hypertension, and I learned a lot on myself. And as the doctor always tells me I'm obese, I tell him I'm pleasantly plumbed. I'm not obese. So I learned from me, but as I have a passion for my community, a passion for empowering women in the community, black and brown community, and when I look at the handful of us who are in here and the information given today, I'm just asking, and I know Dr. Camacho heard me talk about it this week, where do we go from here? Because we have persons out there, they are not privy to being here. They are not able to hear this, and I know how you presented it, then you'll have to break it down for them in layman's terms, that they could understand that the things that they do, the things that they put in our bodies. Because when you look at our community, we look at East Flatbush, we look at Bronxville, we look at different area, Bed-Stuy. What do we have in the community? When we look at our communities, what comes in our community? We get fruits coming to our communities, but they are mold. When you open the box, it's already molded. It's rotten. But then we go to a different area, fresh fruits and everything. During COVID was prime example. Persons were getting, in certain areas, they get the turkey, they get chicken, they get everything. And then whatever comes out, when we open it, the fruits came to our church. We had to throw it out, right? So every time you look around, it's like a bodega, it's like a fast food, and what are we feeding our children? And the persons who are less fortunate, they are not able to go to Trader Joe's and able to go to the other places. What are they eating? And I think that our people in our community, they need to be empowered, they need to be educated. And then everything that was said here today, a lot of persons, when they live here, are they going to share it? Are they going to go to an organization that they are part of and say, hey, you know what? Let's bring this group of women together. Let's do whatever we understood. Let's translate it to them in our language so that they could understand. Where do we go from here? So that is because we need to do more. It's just not being here, we are talking, and it's wonderful, but then there are persons out there, the message is for them, and they really do need the message. What do we do? How do we go? How do we mobilize other community-based organizations, and then we can give them that message, and they too can work with the district that they are working with, the clients that they are working with.
Thank you so much. I have also spoken to, or my team has interviewed Jamaican families, young people, mothers, grandparents, and spot on. You said all the same things. What I want to say, where do we go from here? Brooklyn College has established the Brooklyn College Cancer Center, and part of our mission is exactly to connect to the communities around us. We're a hop, skip, and a jump down that way, I think. And we want to hear from you, just like my research agenda started, you placed perfectly, yes. Started from asking, so part of being a researcher, I was trained in public health. Part of it is whatever presents to you is your problem. You have to help solve it. And my students brought these issues to me, and the research was absent. If you look in the databases, the only people who write about this in New York City is our lab and one lab at Johns Hopkins. But we want to work with the communities. We want to hear, how can we help? And how can we, part of it is, it's not just education, because education puts the onus on the people who are suffering the effects of the systems that we've created that produce unhealthy people. So we need to talk to politicians, but you need to come with us. And we need to talk to zoning, people who create the zoning. We need to talk to Dr. Rundle, clearly. But we're open. I'll give you my contact. You have Anna's contact. Please stay in touch. We want this to more people.
I work in the community. I am the chair for the board at Kings County, and I work in the mayor's office as a human rights specialist.
Yeah.
And outside of that, I'm chair for the health committee at the community board. So I try to be out there in the community, and I tell persons when I go out, and it bothers me because when I say, hey, I'm here, use me. I want to work because I know I'm outside in the community, so I know the need. And I would give persons my card, and then it's like when they get that, they just straight to the side. I don't hear from anybody, and it is my passion, because I want to see change in my community, because many times, and as you said, I have met with several politicians who sat down and said, yes, we have been talking about, but when you leave, what happened? You know, it's just like what happens in Vegas stays in Vegas. So when we leave, and everything is forgotten. But there's much work that needs to be done in the community, and we need to come together to do it. We need to collaborate.
Yeah, so I think all of us on this board, and even Dr. Camacho-Rivera, like many of us we're interested in developing these academic community partnerships, right? All of my studies have a community advisory board. I'm going to reach out to you because I have a specific study that I think is directly relevant to everything that you're saying. The work that, tell me your last name again.
Just Dr.
Romanovsky,
Margrethe.
right? Like the work that she's done looking at disaggregation, we've been doing that in New Jersey as well. I think it's all about collaboration. It's all about, reach out to us. Is there something that you feel that your community might want a presentation about? Like I give presentations to community organizations. I'm part of community organizations, and I think all of us are here to do that. Like that is our role as public health professionals. So trust me, I'm going to reach out to you.
Was there another question in the back?
Hello.
Yes.
My question was for Dr. Llanos. Is this how you say it? Okay.
Yes.
I was wondering if there was a specific reason why the allostatic load had to be separated between lipid and inflammatory. Is it because you get like confluence of data when you merge all 6 different things together?
So it doesn't have to be separated. What we're trying to do in my lab is actually develop a standard measure. So what I tried to convey in my presentation is that when you look across studies looking at the relationship between allostatic load and many other health outcomes, it's computed in a different way. So if we can have this consistent measure that we know is, assessing that the thing that we're trying to address, then we can use it moving forward. And so that we know that the findings are, valid, reproducible. Mm-hmm. So we just wanted to test those 2 measures based on prior work in allostatic load.
If I may add, the thing, I have also worked on allostatic load. The thing about having multiple variables, the more blood tests or urine samples or other measurements you need, the more expensive and more invasive a test gets. And the less likely it is to be used, or the less likely the data is to be available.
Right.
Mm-hmm. All right. I think that will be our last question before we wrap up. For closing remarks, just want to extend a huge thanks again to our panelists for their great presentations. Thank you.
I think the first order of business is to thank Laura Martel-Rooney for another year. Second is to really thank our speakers who took the time to prepare the talks and, wonderful presentations. So thank you very much. And then to our moderators, you all did a fantastic job moderating the sessions. So thank you very much, moderators. So the question is, where do we go from here? I think I like your way of putting it. Obviously, we are very interested in a number of things. The first thing is we have to solve the problem ahead of us. The problem is cancer health disparities, and we want to solve that problem. That's why we have this conference. So the first step is to have the conversation. We come together every year, we talk about it. That's number one. The second thing is we create collaborations. So as we talk about it, we make new friends. And then we have people with different ideas, and the different ideas don't always have all the answers in them. And then they sort of crisscross and find each other, and then we form those collaborations to find new questions to new problems and try to dig into the solution to those problems. So that's the second thing. And the third thing is we have to write. right? All the stuff that we're talking about, if we don't write them, nobody knows about them, nobody's going to read about them, so we try to write them up. And the last piece is we need to get the funding that is needed to be able to do this kind of work in a very large scale. At Downstate, we've done that. We've been funded continuously from 2000 and maybe 12 till now. We try to get grants to be able to support these kinds of activities. So that is what we need to be doing. I'd like to thank the partnership between SUNY Downstate, Cold Spring Harbor, North Weill Health, and the Brooklyn Health Disparities Center for working together for all these years to try to come together every year. And actually, we write grants as a group to try to promote the mechanism to answering all these questions. But whatever we know is just a little bit piece of what we don't know. So there's just a lot to be known. And so the more we come together, the more we speak about it, the more we uncover the stuff that we just don't know. So I think it's very important that we advertise this conference. Tell your friends, tell your colleagues that there's a conference like this at Downstate every year. We would like to have them participate in the conferences. You would hear from us after this meeting. We have a consortium that is planning different kinds of grants. We are in the middle of some of those grants already, and if you can participate, that would be great. The last thing I want to mention is what we have done directly at Downstate to address these kinds of issues. We have a Brooklyn Health Disparities Center. The center is an academic community government partnership. It is SUNY Downstate in partnership with minimum 42 community-based organizations and the Brooklyn Borough President. And the Brooklyn Borough President's office basically has all the community-based organizations. So technically, we are in line with all the community-based organizations in Brooklyn. So it's very, very powerful when you're working with a partnership where you're actually able to reach the community in ways that you don't even understand. So we have been doing that for years. The second thing we're going to be doing is actually moving the conversation beyond the Brooklyn Health Disparities Center. Starting from the spring, we're going to be establishing what we call the Brooklyn Health Equity Institute. We're moving from the Brooklyn Health Disparities Center to something bigger. It's going to be called the Brooklyn Health Equity Institute. You'll be hearing more about that. It's funded from the NIH. We got $10 million about 5 years ago. We got another $10 million just 6 months ago. And with the $20 million, we'll be funding this Health Equity Institute, and that would expand some of the conversation that you're talking about. The Health Equity Institute is going to be an academic community government partnership. We're going to have enough space. Some of the funding is going to have enough space to create community spaces where community members can just walk in any time, and they'll be able to interact with health disparities experts and be able to answer any question, be able to participate in the trial, and be able to be an ambassador in the community in various kinds of subjects. So we're looking forward to that. So on behalf of my colleagues and the dean who came this morning, I'd like to thank all of you for coming, and then hopefully we'll see you soon. Keep the conversation going. Health disparities is a big deal. We don't want inequities. What we want is the equity piece of it. So whatever you can do towards that goal, you're very, very welcome. And have a good day. Okay.